So today we're going to be going over the basics of a peripheral IV, or saline lock, as you'll hear it called often, and then also move into priming of your IV tubing or IV line, and then finally running a gravity infusion. So to start, we'll just sort of talk about the IV itself, the catheter, and what's inserted. So when we talk about peripheral IVs, we're talking about those IVs most common in the hands or forearms, in those small peripheral veins. So what's inserted when the IV is put in, and you'll learn IV insertions later on in your program. Right now we're just kind of learning the basics, but this is the needle that they use to insert an IV. It's a very sharp needle with a cathlon on it. So they go in, insert, and get it into the vein. And then what actually happens is they'll remove the needle aspect portion of the IV, and they will leave in this part, and this is called the cathlon. So that IV cathlon is what stays in, and it's that soft tipped end, because you could imagine how painful and traumatic it could be to leave a needle inside the person. So just the cathlon is what stays in, and you can kind of see now, maybe start to picture. So this cathlon is in his vein, and then he has this extension set or system that we'll then hook up to and go over how to hook up to. So that extension set, typically the nurse inserting the IV will have primed this extension set with normal saline, and we'll go over that process too in a little bit. So this will be primed with normal saline. Again, you wouldn't want to be touching it the way I am. You want to maintain sterility of this system. So this is sort of, you can imagine it being like this, and the cathlon will attach, or rather the extension set will attach to the cathlon that's inserted, right? Just like this, and it just screws on there to the system. And this is called a one-link port. So we'll go over accessing this, but that is unlocked by using these normal saline flush lure lock syringes. Kind of locks in, and then you can flush and aspirate fluid through here. So this valve kind of prevents anything from moving when it's not being accessed. So we'll put all that stuff aside. So you just kind of better understand the IV and the anatomy of this IV saline lock. So just with those cathlons, I'll show we had a pink cathlon there, so that corresponds with a 20 gauge, very similar to our injections chart, that the gauge corresponds to the size or diameter of the cathlon that's in. So a 14 gauge is rather large, and a 24 gauge is quite small. It's really uncommon actually to see these 14 and 16. More likely what you'll see in peripheral IVs is 18 to 24. And again, you don't want to memorize the color, but you want to know what gauge you're putting in. The color is helpful though once it's already in. That's how you'd kind of want to be able to tell that 20 at this facility is pink, so you would know that this person has a 20 gauge in. This is just showing the clear dressing, so this is that tegaderm dressing. It's got a clear window on it, and you'll see why in a little bit as well. And then this is again that one link lock system here, so it's just right here on the end. Helps keep that closed system. So just to see the different parts. So you'll hear it called a saline lock, like I said, or you'll see it written SL. You may also still hear it called HL or a HEP lock. That comes from a time when they used to flush these with heparin to help keep them open and patent. That's no longer practiced. Heparin is used on certain central lines, but not on any peripheral IVs. So you may still hear people call it a HEP lock or a heparin lock, but know that that's kind of just the old terminology. So when you'll also hear the words accessing the saline lock or flushing the saline lock. Those mean the same thing essentially. So I'll show you how to do that and what that means. For that, you're going to want a pre-filled normal saline syringe, and these are available on units that have IVs. They come in 3s, like this one, of normal saline pre-filled and sterile, or they come in 10s. They also come in 5s in between. So you could choose, really this lock only needs about 3 to 5 mLs to be flushed, so the 10 is a little bit overkill, but so you'd want to open it, and when you do open them, they usually come in a clear package that you'll take them out of. You want to make sure that it is in fact your sterile normal saline, it's not expired, and there's usually a bubble in it, so it's a good idea to kind of, I usually give it a tap on the table and knock that bubble out, take my cap off, and make sure that there's no bubble in there. So sort of push the plunger up so that it's all primed with fluid and there's no bubbles in there. Then we're going to need an alcohol swab to clean off our port where we're going to access, and we're going to clean that port off really well for 30 seconds, which is a long time when you actually time it. So I want to make sure you clean it really well using friction, and I usually cover my fingers with the alcohol swab entirely so that you're not cleaning with alcohol and then inadvertently touching it again with your bare fingers. So we want to clean it really, really well, or we want to only touch it with the alcohol and clean well around and on the top especially. So this is a Lure Lock system, like I said, so you can see the Lure Lock hole or lines there, and same with the port that we're going to hook up to. So the motion is an inward pressure and then turning to lock. So we're going to go inward and turn and make sure that it's firmly locked up. Best practice does indicate actually aspirating first before flushing, just a little bit, because if you do see blood, that is a good sign. That means that it is in fact in the vein. Though I say that, and oftentimes you won't actually see the blood. It's a small peripheral vein, so sometimes that doesn't happen. And you may still well be in the vein. So the best practice guidelines actually do say aspirate. If you see blood, that's just sort of an additional confirmation. But if you don't see blood, that doesn't necessarily mean that it's not in the vein. So you actually would proceed with flushing. So we're going to proceed with a slow flush. And how we're going to know or tell whether this is in the vein or not is by watching this in this window here, talking to our patient. This is where we're looking for any of those complications on the list there. So do we see it swell up immediately as we flush? Is he having extreme amounts of pain? Is there a lot of redness or especially a red line going up it? Any of those things. Is it super hard to flush? Are you meeting excessive resistance, meaning there might be a clot there? Those kinds of things would tell you that this is maybe no longer in the vein anymore. It's maybe gone interstitial. So hopefully it stays in the vein and we can continue to flush and it's flushing easily and he's not having any pain with this. So that's great. So that's flushing an IV or accessing an IV port. So then to remove this, we'll actually just undo it and maintain a bit of pressure there and undo it, twist away, and this can just be discarded. If we were just flushing it to make sure that it was patent and still in situ, that would be the process. And what we'd want to do after that is actually clamp off this slider clamp there so that because the pressure in this extension tubing isn't going to be as high likely as the pressure inside his veins, but you may see his blood back up into the line. So we don't want that. So this, by putting on this slider clamp, helps prevent that blood from flowing back. So that's the principle of flushing, accessing, or locking off a saline lock. And watching for those complications. What we'll practice next or go over next is the priming of IV tubing and then gravity infusion into our saline lock. So there are lots of different types of IV solutions. The different tonicities, you'd want to have a good understanding of what types of situations require which tonicity of fluid or amount of fluid, also which patient conditions require more or less, or what types of fluids. But we just brought out a couple different examples of fluids. So these three here are the larger size. They're 1,000 mLs. So this one, for example, you see the mLs here, 1,000 mLs. You see the expiry date up in this corner here. This one is obviously quite expired, but that's where you'd see that. You see the type of fluid here. And you want to just look at the bag, make sure that it's not got any obvious breaches of its integrity or floaties in it or anything. So we'd want to just eye over the bag. So these are the 1,000 ml bags. That's a normal saline. This is a D5 normal saline. This one I like to point out, even though it's in bright red here, but this one has potassium pre-infused into it. So it's 20 millimoles of KCl, or potassium chloride, with D5W and half normal saline. So if your patient required, say, potassium replacement via IV, then this would be the type of bag, depending on the amount they order. So you want to pay special attention to that because, as you know, potassium can be critical of too high or too low, and you wouldn't want to inadvertently give someone potassium who didn't need it. So just some different examples. This one, similar, but it's a 500 ml bag, so it's a little bit shorter. And again, you see that volume marking at the top and that expiry date on the left and the type of fluid in the center there. This one is called a mini bag. When you get into Skills 3, you'll learn more about piggyback infusions, and this is typically what we use is a mini bag, and we piggyback it onto our larger primary. So this is often used for giving medications in. This one's a 50 ml. There's also 25s and 100s. They look very similar to this. And then finally, just this one I want to show you. It's still normal saline. It's still in the 1,000 ml bag, but this is actually how your IV bags will come. They come in these individually packaged, thicker plastic outer packaging, and so then you just tear it down, and that's how you get your bag. So you actually only want to take a bag out of when it's come from this outer packaging. We just have them already removed. These are kind of noisy too. So that's actually how these IV fluids will come, is in that sort of outer package. So we're going to prime our tubing here. This is a very basic set. It's called Continue Flow, and it shows a picture of it always. There are tons of different types of tubings that you'll learn more and more about for different uses. This one has 3 ports on it, and you can see that in the picture. There's ports, there's a back check valve, and I'll show you all those things on the tubing once we've opened it. But you can get portless tubing that has no ports on it. That's especially helpful when you're running continuous infusions of drugs that you don't want to be mixed with other things. But this is your most basic, probably most often seen set. So I just want to draw your attention to the 10 up in this corner. And what this says is, it says the number 10, and then underneath it, it says 10 drops per ml approximately. So what that is actually your drop factor. That's indicated on all tubing types. So, and you'll see why that's important when we start to calculate our gravity infusion rate. So just to kind of make a mental note of that now. So we want to make sure for IV fluids, especially just like with other medications, that we have an order for them and that the order is appropriate and makes sense, safe for our patient with our knowledge. So this patient does have an order for normal saline. They want 1,000 mLs infused over 8 hours, over the next 8 hours. So we deem that is in fact appropriate for our patient. We've talked to our patient about it. He has a good peripheral saline lock, we've confirmed. So we're going to go ahead and do it. Now, what we're going to go over today, like I said, is the gravity infusion method. It's not typical. It is used in certain specific areas, but more often, especially nowadays, what you will see is infusions being done via a pump. So you don't, just so you know, you may not see or use this gravity infusion a lot because we tend to use pumps more often, and that's okay. It's better, it's a little bit safer and more controlled, but there may come instances where you do use gravity, so we do want you to understand that method as well. So we'll get our normal saline. It called for a 1,000 ml bag, so this is our 1,000 ml bag of normal saline, and we'll pretend that it's not expired here. That's the month and year, and we'll inspect our bag. Say it came out of our plastic packaging. The bag looks good, so we're ready to use this one. So what you want to do is calculate the rate using your drop factor, and I've just sort of pre-done it here. this is the formula that you're going to use. So you're going to do volume times drop factor over time in minutes, and that will give you your drops per minute. So as it was prescribed, 1,000 mLs times the 10 for the drop factor that we got from the tubing. And they're not always going to be 10. Sometimes they're 15. Just depends on the size of the tubing. And then 480 minutes is our 8 hours times 60, so to get it into minutes. And that's going to equal 21 drops per minute, roughly, rounding that. And then I wrote underneath here 5 drops per 15 seconds. So when you take that 21 and divide it by 4, it rounds nicely to 5. So if you want to do a quick check, you can just do it within 15 seconds. But for our first check with gravity, for sure, we want to stay for that full minute or even longer to make sure we're running at that right rate. So this is that calculation that you want to remember. And if you're needing to do gravity, this is the calculation that you would use. So we'll put that aside now that we have it and know it. We're going to do 21 drops per minute. So we'll get right into it. We're going to want to open our tubing. There's a perforated edge along the tubing here. So you just kind of open it that way. Comes out sideways then. It usually comes with this nice paper holder on it, so you just rip that off. And I'm just going to go over the anatomy of the tubing for you. So we have here, this is the spike. It has a cap on it, and you'll probably be able to guess why, because underneath that spike is sterile. We want all this system to remain sterile. Any part that's going to be going or having contact with fluids that are going to be touching the person's bloodstream, right? We want to prevent any sort of bacteremia. So it's got the spike underneath, but we won't want to touch that spike with our hands. This is called a drip chamber, similar to with the tube feeding set. It's drip chamber, so it's a flexible plastic that can be squeezed. It's got that about 1/3 marker here too. A little bit tough to see, but when you're looking up close, you can see it. And then we follow down the tubing to this port, or this device is called a back check valve. And it may not mean much to us just yet, but it's a good little thing to understand for when we do piggybacks or secondary infusions off this is our primary line or our maintenance line. If we were to hook up a secondary infusion, it would actually come off this port. So if you were hanging a medicine, or you can imagine having a tubing with a medicine on this port here, what you don't want to see happen is that med go back up into your primary bag. You want it to infuse into the patient. So this back check valve prevents anything, air, fluid, medication, whatever, from going back up into our primary. So that back check valve makes it all a one-way system. It can only go this way. So back check valve. Then underneath that, like we just talked about, our first port. So you're probably thinking that looks a lot like that one-link system, and you're right, it's very similar. It's got that lure lock access point, so it's closed until you access it. So that's our first port. And then if we follow the tubing down, before we get to our second port here, we actually have some clamps. So this is known as a slider clamp, or sometimes I like to call it the on-off clamp, because this one is either open or closed. It has no in-between. So right now it's open, it can spin, fluid can pass, but if we wanted to lock it off, you just slide it over the tubing and it kinks that tubing so it occludes it, just like the one in our extension set did. So just occludes that tubing either entirely or not at all. And then we move down, and this one is called a roller clamp. So similar to the one on your tube feeding bag, this one can be sort of only partially open or partially closed. This is the one that we're actually going to regulate the drops with. So if you were putting this whole system into a pump, you would actually want to keep this one open once it's running through the pump. But for our purposes of gravity, this is actually how we're going to regulate those drops, either slow them down or speed them up with our roller clamp. So you get the impression when you roll it down, it tightens its grasp on the kinking of the tubing, and when you move it up, it's loose and it can be moved around, so the tubing is open and can run. And then you have your second port, same idea, and your third port very near to where it hooks up to the patient, and this is where it hooks up to the patient here. So another thing to mention, and you probably could have guessed this, is this cap will come off, and that's what we'll hook up to our patient's IV. We don't want to touch this either, right? This also needs to remain sterile. So what's best actually is when you open a new set of tubing, just leave that cap on. I think a lot of times students are surprised that you can prime through this cap. It'll actually drip out the sides. It can prime with this cap on still. So we'll just demonstrate that priming method. So when we do go to prime, you'd want to hang your tubing bag up so that you can spike it, and then gravity will help push it through the tubing. In the skills lab, these are reused old bags, so if you pulled off this blue tab, what will happen is the fluid will just come gushing out. So we actually will ask you to flip it over and do it that way. So this is the port that we're going to be removing to spike the bag. This other port you see is used if you're going to instill medication into your bag, which we're not yet in this case, so don't worry about that too much yet, but just so you know what it's there for. So like I said, because it's a used bag, we're going to just take care to flip it over. We're going to pull that cap off. And this just gets discarded. It's just a rubber stopper. In lab, though, we will ask you to keep them and recap your bags after so we can reuse it. Then we're going to carefully, you can use a one-hand method or two like that, going to remove the spike cover. And again, being very careful not to touch that, not to touch the tip of our end of our bag either, and we're going to insert it into the bag. And here, like I said, the diaphragm has already been broken because it's been accessed before, but when you do start with a fresh bag, you will find that you have to apply a little bit of a twist and a pressure to break through this sort of seal that's in here. So give it a good push, make sure it's well on your spike, and now we can actually flip our bag and system back upright, and it's already flowing, so we're just going to lock it off here. Typically, it doesn't flow that fast. It kind of depends, but what you're maybe going to need to do or want to do is actually squeeze your drip chamber to get the fluid flowing there. So give it a little squeeze, and you can see that it fills it. So now what we're wanting to do is prime this tubing. And we talked about priming when we did the tube feeding through gravity and with the pump set, and we talked about that it wasn't as big a deal if there was a little bit of air because it's going into the stomach. In this instance for IVs, we care about air. We do not want any air to be instilled into our patient because there's no known amount of safe air that can go into the bloodstream. So you want to just look through your tubing. Sometimes it's just kind of one run through and you have no bubbles. That's not typical though. Where the bubbles tend to collect, and you may not know this right away, is in the ports that we went over. So it's not a bad idea to have sort of a towel on the floor or a garbage can to drip into. You're not going to like we said, you're not going to let this rest in the garbage can or on the floor. I know it's covered, but that the floor is dirty, and we want to keep this part of the system as clean as possible, and the underside sterile. So don't let that drag on the floor or drop onto the floor into the garbage can. That's not good. So we'll flip our port upside down. So this is right side up, where the port faces the primary bag. We flip it upside down to get the air out because air floats up, right? So we want the air to keep moving through the system just like that. And I'm just using my roller clamp to let it drain out. So you can flick your ports and any bubbles that are sort of sticking around, and you basically just follow those bubbles down your tubing set and make sure that they are extracted from your tubing. And so you want to do that all the way down, and you're paying special attention to every port along the way, because again, that's where the bubbles tend to sort of get caught up. And using your regulator clamp so that you're not kind of overdoing it or underdoing it. So you see the bubbles, you flip your port upside down and flick your bubbles. If your port is right side up, your bubbles will go back up, and remember that back check valve won't let them go any higher than here. So you're not really doing yourself any favors by flicking them back up. So we're just going to follow them all down. Sometimes you got to kind of flick that tubing to get it going. We just have a towel to dry it. You wouldn't want to leave a big wet spot anywhere. for obvious fall hazards or slipping hazards. Just going to open this up a little more, run it a little faster, get it moving. And this process becomes faster and faster, and you become more and more capable of doing all the different things at the same time, sort of flicking the tubing, regulating your roller clamp, checking to make sure your end is not dropping on the floor or in the garbage can. We're just going to flick that last little bit out, and we're going to close up our clamp. So now we're ready to go. So we've primed our tubing, and we maintain the sterility of our spike and our bag and our tip here. So now the next step would be to regulate our flow, because we want to regulate the flow with gravity. So it's maybe hard to see, but basically what we're going to do now is with a watch and watching these drops. So you actually, it's helpful to hold up your roller clamp and your watch so it's all sort of handy and visible, and you're going to start that counting. So we wanted about 21 drops per minute, so you're really just going to start estimating what that is and timing it maybe in increments of 15 seconds, and then waiting for a full minute to make sure you get that 21 drops in a minute. So you can see it dropping, and you're just going to be counting those drops. 1, 2, 3, 4. That's probably a little fast. So then you're just going to want to tighten up your roller clamp a little bit. So you will want to make sure you're at that accurate drop rate before you hook up to the patient, because you don't want to be doing that regulation when it's hooked up to the patient already, because you may be inadvertently giving them too much fluid or not enough. So you want to kind of do it. It will make things a little bit wet, but that's again sort of one of the minor downsides of using gravity. The other one is obviously that at any time somebody could come and fiddle with the roller clamp, or maybe the person lies on it. So we do prefer the pumps, but like I said, it is a good skill to understand and know that you can use if you were to need it. So we'll just say we've got our 21 drops per minute here, and now we're going to hook up our tubing to our patient's IV and let it run. So we're just going to clean our port again really, really well. And we're going to do a flush again because we're accessing the port. So again, we have, this time we're using the 10 ml normal saline syringe, pre-filled. Doesn't necessarily need a full 10, but we'll go with it. And we made sure already that there are no bubbles in here. And we're going to go ahead and flush. So again, locking it on there. And we're going to ask the patient how they're feeling, monitor the site, etc. We're going to aspirate first. Make sure you undo your clamp there or it won't go, and you'll think you're meeting other type of resistance. So just flush, and now we're going to hook up our IV here. So you'll notice that I continue to hold onto this port without touching it after I've cleaned and flushed. What you don't want to do is let it go and then go to do something else and come back to it and not re-clean it. So as long as you're holding it and maintaining that you know nothing else is touching it, you don't need to necessarily re-clean it at this point. But if you're unsure, you think something might have touched it somehow in between there, just re-clean it. It's always best to be clean and safe than kind of in a hurry and give them an infection. So this would be the system kind of all hooked up and running via gravity for the prescribed amount of time, which I believe was 8 hours. So we'd let that go. The other important thing is to document on your ins and outs. So we'd want to document that we hung a 1 liter bag of normal saline for our patient. And then when we take it down, we want to indicate the amount that was absorbed. So those sheets are a little bit different everywhere you go, but this is an example of the one, say, used at HSC, where they write the date along the top. So each column represents 1 day. This is specific to IV fluids. You're putting the time it was established and then the time it was taken down, or what was when you're writing the absorption. And you're writing the code, so normal saline is NS, your initials, what you hung, and then what infused. So this one example, we're saying that after an hour we ended up taking it down, so he only got 125 mLs total of that normal saline, just for an example. St. B's form is relatively similar. It's kind of the same, the columns here, so you're writing the time and the amounts absorbed and the type of fluid, and then they also have an hourly IV check, so that's where you would write that 125. That's what's running at the rate that we've calculated per hour. It's going to run 125 mLs. So that is the basics of gravity, your ins and outs, etc. I'm just very quickly going to demonstrate removal of an IV in case, say, your IV wasn't working anymore, it was occluded, or it had gone interstitial. We can remove it. So he luckily has two. Maybe he only needs one now, or perhaps none. Or this one we found had gone interstitial. We couldn't flush it anymore. It was causing extreme pain. So we're going to remove that IV here. So what you want to remove an IV is a cotton ball or a gauze pad, a 2x2 in its package, and some tape. And we're going to, you may also want adhesive remover, but not always necessary. We'll put on gloves for this. We're likely going to come into contact with blood and body fluids. And we're going to start by peeling off the tape. I usually start by removing the extension set here. It's usually taped down. And as you can imagine, on the arm where there's hair, it can be kind of uncomfortable, so just want to be gentle. Some people want it removed quickly. So a good way to remove the tegaderm is to kind of remove it, and you want to stabilize your cathlon there too, just to make sure you do that. You want to remove it around the perimeter first. Again, stabilizing your cathlon there. And a good idea is to have your gauze or your cotton ball ready and just kind of place it over top there. And so you're removing that in a kind of fluid motion, throwing that in the garbage, and just applying a little bit of pressure, not too much here on the cathlon tip, but just a little bit of pressure, and then you're going to remove your cathlon along the line of insertion. You don't want to bend up, and you don't want to rip it out super fast. And then we're going to inspect our cathlon tip. It's not usually so bent, but because of Jake kind of gets a little bit bent out of shape, but you want to make sure that it's all intact and that you don't have a piece there that's potentially left inside the patient. So cathlon is intact, and then this would be disposed of typically in a biomedical waste or sharps container, even though it's not sharp. And we will apply tape and some pressure here, especially if the patient is on anticoagulation therapy or just tends to bleed. We want to put a little bit of pressure there and make sure that they clot, so they're not bleeding excessively through that site. Make sure they're okay, and we would document that we removed this IV cathlon and the catheter was intact, and why we removed it, maybe because it had gone interstitial like we said. So those are the basics of the peripheral IV setup.